very pleased today to have two really great speakers, Prerna Singh and Yanzhong Huang, who I'll introduce in a second. Just a couple of points of information before we start. So this session is being recorded, so just to bear that in mind. We will, in terms of our topic today, is the politics of managing COVID-19 in China and India, a comparison. And the webinar will explore the ways in which political factors have shaped policy responses in COVID-19, and especially the relationships between more scientific technical analysis of the crisis and political forces. And we have the comparative cases of the two largest, most populous countries in the world with quite different political systems, and we have two ideal people really to share their thoughts on this. So I'll introduce both speakers first. So our first speaker will be Prerna Singh, who is Mahatma Gandhi Professor of Political Science and International Affairs at Brown University, particularly connected to the Watson Institute. She's very well known for her book, How Solidarity Works for Welfare, Subnationalism and Social Development in India. And she has a number of an ongoing work that in a comparative context around public health in China and India, which I'm sure will inform this discussion as well. Our other speaker who we're really pleased to have is Yanzhong Huang, who is a senior fellow for global health at the Council on Foreign Relations in the US, and is also professor at the School of Diplomacy and International Relations at Seton University. He's written a number of books, including Governing Health in Contemporary China, and a book this year, Toxic Politics, China's Environmental Health Crisis and its Challenge to the Chinese State. Both speakers are based in the US, which has a national holiday today, so we're giving our thanks to them, for them giving us our time on this day to still come and share their thoughts on this seminar. When and so without further ado, we'll move into it. We're going to have about 20-25 minutes of comments from the two speakers first. Both speakers are really keen to get your thoughts, your comments, your questions. I think ideally, if you're willing to, please use the blue hand to raise your hand. It's good to actually hear people's voices as well, and see people if they want to turn the video on. But you can also, of course, use the chat function if you would like to do that as well. So I'm going to pass over first to Prerna. Thank you again for joining us.
Thank you, Rory. Thank you, Sam, David, Freya, and it's great to be here with you, Yanzhong, and all of you. So I want to begin by saying that, I'm not, so as Rory said, most of my research is on questions of social welfare with an emphasis on public health, and on the other hand, on questions of ethnicity and nationalism and us and them boundaries. And so what I thought I would do today is really just structure my remarks for about 10 minutes around 3 or 4 broad issues. And the first has to do with the kind of immediate response of India in terms of what they have done and how that has evolved, because we've been, as we all know, only too well in this pandemic for a while. And so that's kind of a first overall kind of national level comments. The second set of comments have to do with the fact that, like the US, as Rory mentioned, we are here today talking about the world's 2 most populous countries. But India is the world's largest democracy, and both Yanzhong and I come to you from the world's 2nd largest democracy, where democracy has been in peril for a while. And so what I want to kind of also do is bring in some comparisons from the US and talk about the peculiarity of India as a federal government. And so that's the second set of brief remarks I want to make. And finally, I want to talk about what was happening in India when the pandemic broke out. I have a fellowship this year at the Center for Advanced Study of Behavioral Sciences at Stanford. And so they have just announced that they're going to have an in-person spring semester. And so in the course of the last few weeks, in addition to everything else, I've been trying to find myself a house in Silicon Valley, in the heart of Silicon Valley. It's interesting, you always get your iPhone with the Cupertino weather. And so now I'm actually looking for these places. And so I've learned this phrase from these millennials or post-millennials that I've been trying to kind of negotiate with on housing leases, called the before times. I hadn't heard about this. So what I want to do finally is talk about in India what was happening in the before times, what was happening in kind of the broad political situation when COVID-19 broke out, and how those kind of pre-existing political conditions have influenced the nature of the response, particularly as regards the nature of ethnic relations and nationalism and us and them boundaries. So I'll begin by saying that, in a way, Rory began, it's Thanksgiving in the US, and I want to begin on a kind of slightly personal note, just to kind of point out in a way how real the pandemic is in India and everywhere in the world. I mean, it almost feels as if we shouldn't have to say this, but, as I kind of still go for walks and see the number of people in my neighborhood not wearing masks. It is something that I feel. So my parents are being discharged today after a long stay in hospital from COVID-19. And so, of course, that's just one data point, and were privileged enough and lucky and fortunate enough to get the best medical care. Rory and I were talking about the availability of remdesivir, dexamethasone. And so, that in a way is a very privileged data point into the crisis. But as we know, it doesn't bear repeating that India has had one of the worst cases or worst instances in terms of the number of infections, not so much in terms of the number of deaths from COVID-19. So what was the kind of broad contours of the Indian government's response? And so at this national level, the first part of what I want to talk about, the Indian government actually put in place a very strict lockdown, which some of you might know about. And this was generally lauded by the World Health Organization and a number of kind of important players in the global health situation. Everyone was under a very strict lockdown. This was announced with very little notice. And from a public health perspective, it seemed exactly the right kind of thing to do. You stop the chain of transmission, you try to flatten the curve. However, the one aspect of this lockdown, which has of course now been spoken a lot about, but we talk about state capacity. And so I've been involved for some years in SAM and the Rory's kind of broader project about state-society relations. And so the one interesting thing about the Indian government's response was, as a state, one wonders about the Indian state's level of ability and capacity. And I think this will be an interesting point of comparison with Yanzhong in China. But I think independent of state capacity is the question of state will. Like, what does the state want to do, irrespective of what it can eventually do? And so Lant Pritchett, who was also at the last ESID conference that Sam had organized, has this concept of a flailing state to describe India, in which he says, the head of the Indian state, this kind of bureaucratic, technocratic brain, is actually amazing. What happens, so it's great policy making, what happens is that the state flails because the head is not attached to the body, the kind of sinews of the state, especially as it gets into the local areas. And so the problem becomes one of the implementation of these quite excellent policies crafted by the head. And so, the problem comes when the rubber hits the road. The reason why I mentioned this is because in the context of the COVID-19 response in India, I want to venture and provocatively say that this was not India's classic flailing state problem. This was actually a situation, and this links back to my third point about what's happening in India before the pandemic, or what were the political situations in which the virus broke out, in that this was actually a question of the state not thinking through, perhaps willingly, about what policies needed to be put in place. And I'm talking here in particular about the urban migrant crisis, which many of you might have heard about. So India goes into a strict lockdown. There are hundreds of thousands of migrant workers who, like in China, are employed in the cities, but have families and live back home in the villages and have very temporary living situation than employment situation. So in the strict lockdown, these hundreds of thousands of urban migrant workers are basically left with no source of livelihood, but also no way to make it back to their native hometowns. And so this is where I say that it wasn't so much a flailing state problem. It was the fact that the state, it appears, really did not think through or care enough about these most vulnerable, most marginalized populations in order to actually put in place a plan. And so there were these completely heart-wrenching photographs documented by one of India's journalists, Barka Dutt. She spent, hundreds of days on the road documenting the plight of these migrant workers who in many instances walked hundreds of thousands of miles, dying from dehydration, dying from sheer exhaustion, from lack of food. And the state for many weeks did not come in. So whatever relief came in was from non-governmental organizations. And so this is the, so on the one hand, from a public health perspective, and it's important to keep in mind that the Modi government has really tried very hard to project this image of India into the world as this kind of emerging power, often with the kind of contrast of China lurking there. So from that point of view, it all was great. The India was doing exactly what the WHO had recommended. It was being patted on the back. But in addition to the public health crisis, because of the sheer lack of will and foresight and desire to be there for the most marginalized and vulnerable people, there was this humanitarian tragedy that was added on to this public health tragedy very early on in the pandemic. And I think this, I began with the case of my parents. But I think here, like in China, India is a very unequal society. So what did it mean for India to kind of follow the letter of public health recommendations without taking into consideration its own realities? So one was, of course, the urban migrant crisis. The second was, what do living situations look like? An average of 7 to 8 people in a one-room settlement, a tenement in India's what are called slums, informal settlements. So this idea that social distancing is a luxury. What does it mean to shut down the economy when there is, almost no savings for these people to rely on? And so there was this kind of general idea in the media that the lockdown was meant for this idea, people like us, people like me, people like my parents, people who were educated, who wanted the chain of, who wanted to be safe from the pandemic. But there were these kind of twin plagues that were emerging along with the pandemic that were disproportionately affecting those who were anyway more likely to be fiscally and from a health perspective more vulnerable. I mean, we know from the work of people like Jishnu Das and a number of other people that spending on health is one of the leading causes of impoverishment, which often leads into cycles of debt for generations for Indian families. So on the one hand, from a global perspective, India does it all right. But from the point of view of the most marginalized and vulnerable, the Indian government displays a shocking lack of not just capacity, but in this case, will or desire to think through what this kind of, perfect public health lockdown will mean for them. So that's the kind of broad contours of it. I don't want, so since then, the Indian government's response has evolved. There has been a kind of opening up. But as we speak, much like in many other parts of the world, here in the state of Rhode Island, which has, so I'm kind of now segueing into my second part of the comments about federalism. The state of Rhode Island is going into something called the pause, in which bars and restaurants are beginning to shut again as of today and Thanksgiving. So India is similarly kind of rolling back this opening right now. But what I want to kind of now pivot to from this kind of general national level comments is to talk a little bit about the fact that India is a federal government. And so Rory mentioned my first book, which is a comparison of Indian states. And India is a linguistic federalism. So different states in India are usually correspond to different linguistic groups. And so one of the dimensions of the COVID-19 pandemic, which doesn't come as a surprise to someone like me who studies variations in Indian states, is that the picture looks very, very different where in India you are. Of course, the picture looks very different where in the US you are. State of Rhode Island with Gina Raimondo, who made it to Time and Newsweek and the New York Times as a very proactive governor. I'm much safer here than I am in other parts of the US. But just to give you a sense of what the pre-existing differences in public health looked like within the overall federation of India is that India is a very symmetric federal country. And so Indian states are bound by the same legal, financial, and electoral systems. But just to give you, one kind of data point into the differences, very stark differences in public health, if you are a woman born in the countryside in the north central Indian state of Uttar Pradesh, which has a larger population than Russia, you're expected on average to live almost 15 years less than if you're born in the South Indian state of Kerala, which is demographically larger than Canada. So, again, the point about India and China both being very, very populous countries. And so these are the kinds of dramatic differences in the quality of life and public health that were already pre-existing when the novel coronavirus hits. So in my book, I've made the argument that actually these differences can be traced back to differences in the strength of subnational solidarity. So states that have a much stronger sense of regional subnationalism are the states that have shown a much greater willingness to be able to prioritize the collective good, including public health and education. And society, the question of popular compliance, I think, becomes very key. We're going to see that, especially as, now the vaccine, fingers crossed, begins to be rolled out. So in these cases of a stronger sense of what I call we-ness or mutual obligation, societies are also more likely to come on board and comply and cooperate with state health and general welfare directives. And so just in the case of COVID-19, very early on, Kerala, along with countries like New Zealand, or Vietnam, began to be hailed as this kind of exemplar of a very proactive COVID-19 response. And just to again put it in perspective, Kerala has one of the highest rates of population density. It's also one of the most ethnically fractionalized states in India in terms of very large Muslim and Christian populations. And also it's very deeply connected to a Malayali diaspora. So they have, some of the largest rates of people coming into Kerala, and they still did an exceptional job, mostly again following WHO guidelines of testing, quarantining, isolating, but also kind of providing public welfare rations, food rations, a large army of volunteer contact tracers. And so, just to kind of put it in perspective, there are these national level responses in countries, but then within India, Kerala, for instance, has been a state that, following its generally positive trajectory of social welfare, did really well. And to me, it was building on this kind of pre-existing health infrastructure. But the fact that it could tap in to this kind of pre-existing solidarity to get people to comply with these public health directives, which involve a lot of sacrifice, staying at home, wearing a mask, but then also being able to mobilize very quickly this large volunteer force in order to kind of provide mental health support. In Kerala, the kind of, in a way, the dark side of Kerala is also that it has one of the world's highest suicide rates. And so, there was this large volunteer force that was there to provide mental health support, to provide public rations and food, and also to help with the actual immediate fallouts of the pandemic in terms of helping with quarantining and contact tracing. And so that's the one thing I want to point out, is that to some extent, it becomes meaningless to talk about a national level response without paying attention to these state level distinctions that are even clearer in a federal country like India. And I want to end on this third point, which is about what was happening in India when COVID-19 broke out, the before times, as I've learned now to call it. So in the before times, India has a Hindu nationalist government in its second very emboldened term in office that has long espoused an idea of India that violates a very secular, inclusive, syncretic idea that's enshrined in the Indian constitution and follows on from the Indian nationalist, the anti-colonial movement against British rule led by Nehru, Gandhi, and the Congress Party. So the BJP, following on from Godse, so Mahatma Gandhi was assassinated by a member of the civil society organization. So just to kind of give you a little bit of a historical idea of the fact that this was a contesting vision of the Indian nation that goes back to the time of independence itself, in which Gandhi and Nehru were seen as traitors to the Hindu idea of the nation. So this party now it has an absolute majority. It doesn't need coalition partners. So this is a very new kind of power that this BJP government wields. And in its especially second term, was elected back in 2019, it has shown a kind of really deliberate agenda of implementing this idea of India as a Hindu nation. And here, of course, the main other, the them for the Hindu us, are Muslims. And so when COVID-19 broke out, there were unprecedented social protests against two very important institutional interventions that the BJP was trying to make in order to marginalize Muslims as residents and citizens of India. One was the National Registry of Citizens, in which Muslims who had lived in India for generations would have to kind of prove their being Indian and their residency. And there were these large, like prison-like structures that were being created in order to house mostly Muslims who were unable to show this kind of residency. And the second, most immediately, was the Citizenship Amendment Act that made it, that basically discriminated against Muslims seeking asylum or becoming refugees in India. And so on the one hand, there were these laws. On the other hand, this was the high tide of social mobilization. Hundreds of thousands of people were on the streets of India. And I wrote an op-ed in the Washington Post about this. They were, claiming Indian national symbols. So they were waving the Indian tricolor. They were standing with pictures of Gandhi and Nehru and Ambedkar, who drafted the Indian Constitution. They were singing the Indian national anthem, saying this is not the vision of India that we stand for. So this, the kind of BJP's institutional attempt to impose its idea of an exclusive idea of India, along with these protests, literally people on the streets in Shaheen Bagh, in India, in Delhi, was the context in which, of course, the novel coronavirus breaks out. So for one, and this links back to the first point, it's a tremendous gift for the BJP government, because now they can shut down these protests that have been roiling the streets of India for many weeks, all through December. So come March, they now have like carte blanche to remove all the protesters and impose this lockdown. But in a sense, more importantly, they kind of revert to this idea of, the scapegoating of Muslims for the pandemic. And so I've been writing this piece in which, and Rory mentioned, there's this public health book that I've been working on for a while. But the thing about diseases is that they always have the potential to raise these us and them boundaries. And so COVID-19 is not the first pandemic in which we've seen the kind of stigmatization, the naming, blaming, shaming of minorities. We saw that, going back to the bubonic plague and the targeting of the Jewish community, the targeting of immigrants for smallpox, syphilis, tuberculosis, AIDS being called, associated with the 4 H's. So there is the racialization of disease that unfortunately long predates COVID-19. But I think the interesting thing is that it's almost like the analogy is to the human body. We know that people with pre-existing conditions are more likely to have worse outcomes with COVID-19. So it's almost like exclusionary nationalism was this pre-existing condition because of which the social fallouts of COVID-19 were more intense than they might otherwise have been. And in particular, the fact that there was already this kind of us and them, the othering, the scapegoating of Muslims made it very convenient for exclusionary nationalist governments like the BJP government to now also begin to term Muslims as kind of, quote, super spreaders. And just to end with the comparative context, that's not new. We've seen the kind of, obvious demonization of Asian Americans, but across Europe, we've seen the disproportionate policing and victimization of the Roma in the US and in other parts of the world. Again, people who were already anti-immigrant have now, Donald Trump tweeted on March 23rd in caps, this is why we need borders. And so in a sense, the disease, which does not respect borders, has made borders all the more salient. But I'll stop. Thank you.
Thank you very much, Prerna. Over to you, Yanzhong.
Okay, thank you. Let me first share my screen. Okay. Can you see it?
Yes.
Okay. Just okay. Well, I'm going to present on how China managed the COVID-19 outbreak. So well, this is the shows the impact on human health of COVID to date. Now we have globally 60 million cases, well, including 12.6 million in the US, which causes 260,000 deaths, and India 9.2 million with 135,000 deaths. And if you look at China, which is number 61 in terms of the impact of human health, the rank, it has so far a little bit over 92,000 cases. That was 1% of India's, and 400,742 deaths. That was 3.5% of India's. Again, provided that the numbers, the data there's no significant underreporting here. And this shows the number of novel, the COVID-19 cumulative confirmed and death cases in China from January 20th to November 24th, right? So it is very clear that most of deaths in China occurred before late April. In fact, by April 22nd, there was close 84,000 cases, over 4,600 deaths. But after April 22nd, only like 1/10 of the cases before April 22nd, and with only 106 deaths. So you have seen actually significant drop of the cases and deaths, after late April. And in a way, if you look at also the regional distribution of the cases in China, this epidemic looks more like a local or regionalized epidemic, right? We know that the disease started in Wuhan, which is the capital, provincial capital, Hubei province. So Hubei, Wuhan became the epicenter of the outbreak. Hubei was the hardest hit by the pandemic. Even today, if you just look at all these cases in the province, actually it claims about 3/4 of the total cases in China, and 95% of all deaths in the country. And this shows, this is the actual from the New England Journal of Medicine. This is like a timeline on how the government respond to the outbreak in the initial stage of the epidemic, beginning in November, actually December, through January 20th. That was when China announced, formally acknowledged the human-to-human transmission of the virus. So, well, when we know that when any country, right, not just China, is facing a novel virus, right, it takes time to recognize, to define, right, the nature of the outbreak, and then to launch response to the crisis in a timely and effective manner, right? It is a challenge, but the question is, does that justify the initial mishandling of the outbreak? Right? We have seen, right, this cover up and inaction essentially delayed the response by at least 2 weeks. Right? If you look at there's certainly smoking gun evidence pointing to the initial cover up. When, for example, the infection of healthcare workers in Wuhan had already been an open secret in the frontline hospitals in the city by January 10th. Right? Local government continued to deny there was a human-to-human transmission until January 20th. Right? It also disciplined whistleblowers, right? Doctors like Dr. Li Wenliang, right, who tried to alert people about the outbreak. Then if you look at the inaction, right, basically local government did not ask people to take preparation measures, precautionary measures, right? They went forward with an annual potluck banquet on January 18th in that neighborhood called Baibuting, with more than 40,000 households participating. And until January 20th, but in Wuhan, a few people wore masks, were even encouraged to wear masks. There was a huge problem in terms of lack of testing capacities and hospital beds. Indeed, until like early February, they had like fewer than 2,000 cases of test in terms of testing capacity. The health system, not surprisingly, when the government announced, right, the outbreak, the entire health systems are overwhelmed, by the people who are seeking, right, hospitalization, who are trying to get tested. Right? So that delayed information sharing and inaction might have contributed to the fast spread of the virus domestically and internationally. Right? There was a study suggesting that had the government acted upon the outbreak early, by 2 weeks, could actually reduce the domestic cases by 86%. And internationally, right, we know that even though there was a lockdown in Wuhan and beyond, the people were still able to travel overseas. In fact, according to the New York Times report in early April, right, 430,000 people actually have traveled from China to the United States, since the end of December. So the argument can be made, many of those cases, that were found in the United States, actually could be connected to the outbreak in China. But that being said, we know that the similar problem of downplaying, the threat of the outbreak, also occurred by the United States. Right, the President Trump himself admitted, right, he was not telling the truth in the beginning about in the beginning of the outbreak in the country, right, and also. The China's the COVID response is sort of different from its SARS response 17 years before, because this time it appears that local government officials should be largely responsible to the initial mishandling of the outbreak in China. That might, as Prerna suggested, that they had something to do with the local state capacity there, that if this is sort of like a counterfactual hypothesis, but if the same outbreak occurred in Shanghai, the story might be different. So after January 22nd, right, this is the day that when President Xi Jinping ordered the lockdown of Wuhan, the draconian containment measures being kicked off, right? There was the lockdown on Wuhan, then quickly this measure was extended to other parts of the province, Hubei, and then the other parts of China. The government also scaled up the testing and treatment capacities. Right, there's 2 hospitals that could accommodate, more than 2,000 patients in severe conditions, were built within just days. Where the government also converted again within days, 16 those like convention centers into those makeshift hospitals, that accepted the patients with mild symptoms. So you have seen this very strong government mobilization of capacity, that was certainly aided, by high technological means, right? The big data, cell phones, so the government was able to monitor, right, the people's movements, around the clock. That was in a way also facilitated by the so-called this community policing, right? You basically have, the residents, just playing a role, monitoring other their neighbors or other residents' movements. And these measures appear to have worked, right? You see, this is the January, late January, we're seeing the lockdown measures being imposed. The cases and deaths continue to rise until mid-February. But after mid-February, we have seen, right, the cases and deaths began to drop, right, until like the end of the early March. Essentially, most of the Chinese cities, they are being the lockdown measures were lifted, and finally in early April, right, there's the lifting of the lockdown measures in Wuhan, and so after May, we have essentially only saw sporadic outbreaks in the country, right? In Beijing, Wuhan, the Qingdao, the Yunnan, then Xinjiang, this is all sporadic outbreaks, and many of those cases were asymptomatic ones. They were a few cases actually really actually develop into severe symptoms, that led to death, but since May, the government also imposed a new model to handle these outbreaks. This is the policy they call the zero tolerance policy for new infections. Essentially, even after only one case is identified, immediately the government is going to launch mass testing, contact tracing, quarantine, isolation, and also, if needed, then the seal off the cities or high-risk neighborhoods. The government also raised to develop its vaccines, and now they have 5 vaccines under phase 3 clinical trial, and they already, even without the completion of the phase 3 clinical trial, they have already started to administer experimental vaccine on a very large population in the country. According to Sinopharm, their vaccines already being administered on more than 1 million people in the country. In the meantime, China also raised the bar to travel to China, to prevent the imported cases. Recently, they have even asked anybody who are boarding on the plane, to China will have to show the results of the 2 kind of tests, right? The nucleic acid test results and the antibody test results within 48 hours of boarding the airplane. Some people joke that this is essentially say, well, don't come to China. We don't welcome you. So
Yanzhong, sorry to interrupt you just one sec. If just 1-2 more minutes max, if that's okay, so we can open up for the discussion. Thank you. Sorry about
quickly done. So this shows how the Xinjiang is tackling the new COVID outbreak, right? This is the first case was identified in October 24th. By immediately, the government launched the mass testing of all the 4.7 million people in Kashgar prefecture, and all the close contacts were tracked and quarantined for medical observation and testing. So by November 8th, right, this is the again, but it's reset to 0 case in the prefecture. Qingdao, did essentially the same thing. So what this shows indeed a strong state capacity in terms of mass testing, in terms of coordinating interregional prevention and control, right? And society overall was cooperative, right? But when they're deciding to launch these drastic containment measures, well, the local officials, not public health experts, actually play a primary role in the decision making. There is no cost-benefit analysis, no risk assessment, right? If you just look at this mass testing measure in Wuhan, they basically tested 10 million people in 10 days, but identified only 300 asymptomatic carriers, right? And in Qingdao, after the finding of an outbreak in a hospital, they tested 9 million people in the city, but no cases were identified. So this has also raised the issue of sustainability, right? To what extent this, at all costs, by all means, the approach is going to be sustained, especially if you have multiple outbreaks in the country on a more frequent basis. So, and in the meantime, this could be open to the discussion, is that it raises the question of the role of the political systems, state capacity in dealing with disease outbreaks. So with that, I'll stop there. Thank you.
Thank you, Yanzhong, and thank you, Prerna, as well. I think two obviously clearly very, very contrasting cases, but at least somewhat of a common theme in both, not just national responses varying, but also the important role of local government in different ways to